Hi. Hello. 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 Hello, good afternoon. Hello, good afternoon. Hello, good afternoon. Thank you. Hi, I'm George Woolreich. I'm the president and CEO of the College of Physicians of Philadelphia. And of course, you all know, including Dr. Walter Suh, just walking in, knows this is the oldest medical society in the United States, founded in 1787. And although it was founded originally mainly as a library with 17 books by John Morgan, it has grown and morphed into something quite different. It is now, I believe, an extremely vibrant, medically based, medically oriented, cultural, social, and educational organization, with the Karabatz Junior Fellows to take young people and encourage them to think about healthcare careers, the TEVA program for LGBTQ kids to help them with various issues, an herbal garden where if you need your digitalis today, you can go out and find some belladonna and compound it. More than 70 lectures and events during the year, Monday nights, chamber music concerts, mainly with people from the Philadelphia Orchestra. It's a great hall for music, by the way. History of Vaccines website, which goes around the world, and in the last week added Hindi, Arabic, and Urdu to the already Spanish and English on the website. Everybody knows the Mutter Museum, the most famous first date spot in the city, but also the place, I'm glad somebody's listening, you know, but also the place where real research has taken place, such that there's a vaccinia scab from the Civil War that now, under the auspices of the CDC and the World Health Organization, is in Canada being genomically sequenced. We've done things like that before and wound up in Nature and in New England Journal. One of the things about which we are particularly proud, I am particularly proud, is the Public Health and Preventive Medicine section here. The college being the neutral place, the Switzerland of healthcare, not any of the 7 area medical schools or hospitals, is the logical convening place for people with different interests and with similar interests. And with our sections on medicine and the arts, history of medicine, and particularly in this afternoon, public health and preventive medicine, we're holding, again, a citywide public health grand rounds. Some of you have been here for the opioid epidemic, the long-acting reversible contraception, and a topic that some of you know from Sir Michael Marmot's work, the Whitehall study starting 20 years ago, of great interest. Before we start and as we start, I want to invite Dr. Robert Sherrod to come to the podium. He doesn't know that I'm calling him up to the podium, but, you know, be indulgent, be supportive of him. Where's Jackie? Jackie Bowman? Ha-ha. Left to right, Jackie Bowman, Director of Education at the college, Carrie Youngdahl, Director of the History of Vaccine website and Public Health Initiatives, Dr. Jim Buehler, former Commissioner of Health in the city, and the incoming head of the section on Public Health and Preventive Medicine. And to my left, the very distinguished gentleman who years ago set up the section on public health and preventive medicine, ran it for a number of years, then went into semi-section retirement, and about 6 years ago came back and took over the section leadership and has really taken it to new heights, as is witnessed by the turnout today and the support we've had for this. So I thought it very important that the college and the public health community recognize the exemplary action of Dr. Sherrod, his wit, his doggedness, his wonderful ability to work with all sorts of people, and we just thought that should be formally recognized.
Thank you, George. I do appreciate this honor, but I would like to say that I'm proud to be a fellow of the College of Physicians of Philadelphia, and I'm proud to be a member of the public health community here in Philadelphia. We have a great community, we have a wealth of talent, and we should be able to address the public health issues that face our community. So let's work together to do that, and thank you all for this very nice honor.
Good evening. My name's Jim Bueller. I chair the sections committee on public health grand rounds, and as you've heard, I'll be the chair-elect of the section starting next month. And Bob, thank you for all the work that you've done. I'm going to try to emulate the great example that you set in this role. Welcome to our third and final public health grand rounds for the 2016-2017 season on poverty and public health, addressing the causes and consequences. The citywide public health grand rounds has several aims. We aim to address important public health issues in Philadelphia and our region. We want to do that by engaging local speakers from multiple disciplines and perspectives who are addressing the problems we're talking about here in our community, and hopefully to generate new ideas and new collaborations and to strengthen our public health community. The Grand Rounds are co-sponsored by the College of Physicians and by the Philadelphia Department of Public Health, and I'd like to acknowledge our Commissioner, Dr. Tom Farley. Welcome, and thank you for the Health Department's ongoing support. Would also like to acknowledge the Thomas Skelton Harrison Foundation for its support of the Grand Rounds, and the Philadelphia County Medical Society, which provides support for continuing medical education. Please be sure to complete the evaluation form afterwards. We use that to gauge how we can do better. The Grand Round session will go till 7 o'clock, and then at 7 we'll break and adjourn to the room that's just out the doorway and to your left for a reception to continue the conversation. I'd like you to make a note on your calendars. The dates for the 2017-2018 series will continue on Wednesdays at 5:30 p.m. On October 18th, we'll be addressing the prevention of sleep-related infant deaths, the leading cause of post-neonatal mortality, deaths during the period between 1 month and 1 year of age. On February 28th, 2018, we'll be addressing the issue of gun violence and public health. And then on May 16th, 2018, we'll be talking about obesity and its prevention in Philadelphia. So it's with great pleasure that I introduce our moderator this evening, Dr. Diez. Dr. Diez is the Dean and the Distinguished Professor of Epidemiology, as well as the co-chair of the Urban Health Collaborative at the Dornsife School of Public Health at Drexel University. She'll be introducing the topic, introducing our speakers, and moderating our discussion this evening.
So, thank you. So good evening. It's really a pleasure to be here. I want to thank the college and the Department of Public Health for inviting me and for putting together this very important and very timely session. It's not new, as we all know. It's an issue that public health has dealt with since its very origins. But it's important that we continue to talk about it. And I think the focus today will be on what we can really do. So I'm just going to say a few very brief framing comments, and then introduce the four terrific speakers that we had. And I've just like to talk about three principles, and I think all three have implications for the ways we think about interventions. And so I just want to highlight them. Is that okay? So the first is that poverty can be thought of as a fundamental cause of ill health. And what does this mean? It means that it's a distal cause of many different health conditions. It means that there are many mechanisms involved: behaviors, stress, exposures, etc. And it also means that intervening on those mechanisms isn't enough to block the effect of poverty on health. And so this is important when we start thinking about interventions. A second principle is this idea of accumulation, cumulative burden. First, we have the cumulative effects of racism and poverty, which we know travel together in our society and in many other societies. We also have interacting effects. These things potentiate each other. Behaviors interact with stress and with toxic exposures, and they act synergistically to magnify their independent effects. And then these things operate over the life course, and we know that even early childhood poverty has consequences for health later in adulthood. And the third point that I want to make is this idea that there's reinforcing effects of individual poverty and neighborhood poverty. So we know that there's residential segregation by socioeconomic characteristics, including poverty, by race and ethnic characteristics that we know predict health. But in addition, there are place-space features that contribute to these differences, and these things reinforce each other. So residential segregation reinforces differences across places, and these differences across places reinforce residential segregation. And so this is also a cycle that we have to be aware of when we think about ways to intervene to reduce the impact of poverty on health. Just very brief, I'm an epidemiologist, so I can't talk without showing any data. This is a map. It's actually taken from a brief that we developed at the Urban Health Collaborative that you're free to take a copy of on your way out. This is a map of a statistic which is an indicator of segregation of poverty. So it highlights neighborhoods that are poor but are surrounded by poor neighborhoods, and neighborhoods that are wealthy but are surrounded by wealthier neighborhoods. So this idea of spatial differentiation, which is really critical, I think, to understanding the impact of poverty on health and to thinking about how we might want to intervene. These are data which will not be a surprise to you, but it's always, I think, important to look at these kinds of data because it's like, wow, each time you see it. So this is actually data showing a prevalence of self-reported poor or frail health here in Philadelphia by quartiles of neighborhood poverty for the total population and then by race. Of course, blacks and Latinos tend to be more concentrated in the higher poverty neighborhoods, but here you can see that within each group, there's a very clear dose response. This is for self-reported health, a very important predictor of mortality. If we look at all-cause mortality, we see the same pattern. And if we look at years of potential life loss before 75, this is a mental illness, we see the same pattern. And if you look at an indicator like years of potential life loss before age 75, you see an even stronger association, which means that poverty is so strongly related to early death, not just mortality overall, but premature death. And so the fact that there is this dose-response relationship, I think is a sobering reminder that poverty is a powerful predictor. It's a much more powerful predictor than many risk factors that we study in public health. So, with this sort of preview, I'd like to introduce, I'm going to introduce the four speakers. We have four terrific speakers who are going to give different perspectives on this topic, and we'll have plenty of time for discussion. Our first speaker is Giridhar Mallya, who is Senior Policy Officer at the Robert Wood Johnson Foundation. Previously, he was Director of Policy here at the Department of Public Health here in Philadelphia. Our second speaker is Mitch Little, who's Executive Director at the Philadelphia Mayor's Office of Community Empowerment and Opportunity. Our third speaker is Natalie Levkovich, who is Executive Director of the Health Federation of Philadelphia. And last but not least, we're very fortunate to have Imani Sullivan, who is a member of Witnesses to Hunger, and we'll tell you more about that organization and the many important things that it does. You have detailed bios in the program, and so without further ado, I'll have Giridhar come up for the presentation.
Okay, I also want to thank the College of Physicians for hosting us tonight to talk about this critically important issue, and also to the Department of Public Health for being a co-sponsor. I also wanted to start with three themes or principles that I think you're going to hear throughout the evening. The first is that poverty is clearly a public health issue for the reasons that Anna described. We're learning more and more about the fact that poverty, along with stress and trauma, can have impacts on children's brain development, and that can have impacts throughout their life course. The second is that poverty is a moral issue, particularly in a country like ours, which is the richest in the world, maybe in the history of the world. And poverty has real impacts on real people. And it affects them being able to fulfill their full human potential. The third is that poverty is man-made. It's the result of deliberate policy choices that we've made as a society. That may seem depressing, but at the same time it means we can make choices that push us in the right direction. I want to start by talking about a few different aspects of poverty that I think are important to understanding the rest of the presentation. The first is this idea that poverty, we know, is too prevalent in cities like Philadelphia, but what we're seeing is that the gap between the haves and the have-nots is increasing over time. This looks at data over the past 35 years on how incomes have changed based on your starting income. The reason this is important for health is that as income inequalities increase, health inequalities are going to increase as well. So there's data that's come out over the past couple years showing that over the past 15 years, life expectancy differences between the wealthiest and poorest Americans have increased. The second is this idea of wealth. So this gets at income, but also people's assets, whether they have a home or not, a business, their savings. And while we see 2 to 3-fold differences in income by race, we see 5 to 7-fold differences in wealth. The reason this is important is because wealth is a really good predictor of transmission of poverty over generations. Third concept is this idea of social mobility. I think an easy way to explain this is that if you're a child who grows up in a family in the lowest fifth of the income distribution, what's the likelihood that you'll reach the top fifth of the income distribution by the time you're an adult? That's about 14% in Canada, and it's only half that in the United States. And what we see is that there's huge variation across the country in social mobility. And what researchers have found recently is that there are certain characteristics that make Salt Lake City different from Atlanta in terms of social mobility. These are things like the amount of residential segregation and income inequality there is in the community, the quality of the schools, the proportion of households that are led by 2 parents, and then greater social capital or social connectedness. So these characteristics are associated with more mobility. I'm going to shift a little bit and talk about some policy approaches to addressing poverty that might be a little less well known to this audience, but have dramatic impacts on both income and health. This will not be a comprehensive overview of what we need to do, but really just some illustrative examples of what we could be doing more of. The Earned Income Tax Credit is a refundable credit for low-income workers. What's really interesting about this policy is that the credit increases as your income increases, and then it slowly decreases after a certain point. The reason that's important is because it incentivizes people to work, because they can increase their incomes with the credit, and it also incentivizes people to progress in work, because as their income increases, the credit will increase. On average, people that receive this credit each year get about $2,500. That is a big deal when we're thinking about people with incomes of $14,000 per year. It's almost a 20% income boost. People use the income from the credit for the things that you'd expect, for day-to-day necessities, for paying off debts, which are a big burden on poor folks in this country, and also investing in assets. Interestingly, this credit was created in 1975 under the Ford administration, and it's been expanded numerous times by both Democrats and Republicans. So what impact does the EITC have on health? For every $1,000 increase in the EITC, we see substantial impacts for the adults that receive it on employment, poverty, and even the prevalence of low birth weight births for women who receive an EITC. if you think back to the welfare reforms of the 1990s that are now infamous, the EITC accounts for much more in the employment gains that we've seen in the last 20 years than those welfare reforms. For kids in families who receive the EITC, we can see pretty substantial impacts on their educational attainment all the way from elementary school up through college. And the EITC also has significant impacts on their earnings when they're adults. In addition to the federal credit, there are about 26 states that have their own EITC on top of the federal credit. So that means a bigger credit, a bigger impact on the economic outcomes and also the health outcomes of people in these states. Pennsylvania is not a state that currently has one. I think there are a series of reforms that we need to see with the EITC, but I think one big one is getting additional states to create a credit and additional cities. New York City and Washington, D.C. are the only two cities that have a local credit on top of a state and federal one. Next policy example is moving to opportunity. In the 1990s, the Department of Housing and Urban Development wanted to figure out a way to get more low-income families who live in public housing to move to higher opportunity, lower poverty communities. So they equipped them with a voucher, which is very similar to the voucher that about 2.3 million families currently have, which pays for about 30 to 40% of their rent. And then they can use it to pay rent in the private market. In addition to the voucher, though, they gave them counseling and assistance to find and move to higher opportunity neighborhoods. And they compared these families to folks that only got the voucher or people that stayed in public housing. What they saw initially is that about half the people were able to move to higher opportunity neighborhoods. When they followed adults out for 10 to 15 years, the adults who moved to higher opportunity neighborhoods had lower rates of depression, obesity, and diabetes. Now, these adults did not see significant impacts on their own economic outcomes, but we do see these health outcomes. Now, if you follow kids who moved into adulthood, this is what we see. They earned about $3,500 per year more. They had greater rates of college attendance and lower rates of single parenthood. These findings were only present for kids that moved before the age of 13. And the impacts were even higher the earlier kids moved with their families. So there are a series of implications, I think, from this moving to opportunity experiment. The one I just want to highlight is that there are only about 20 mobility counseling programs in the country. One of them is here in Philadelphia. I think those programs need to expand, and we need to cull best practices from the cities that have been doing this well, places like Dallas, Chicago, and Baltimore. What I think these two policies illustrate is can be summarized in the Heckman equation from Nobel laureate James Heckman. The idea first is to invest in kids as early as possible and their parents to have a two-generation approach. The second is to develop environments, so that's in homes, in schools, and in neighborhoods at large that promote both cognitive and social development. And the third is to sustain these supports throughout a child's growth. And I think what you see when you put these things together is impacts on kids' economic, health, and social outcomes. Policy and the safety net that we've created does make a difference here in this country. It's not enough. We need to do more. We need to do better. But you can see what the impacts of programs like EITC, housing assistance, and TANF are. This is a particularly worrisome time to be talking about poverty, as a federal budget was just released, which will really slash many of these programs and fundamentally try to change or reform them. So we need to remain very, very vigilant, be vocal, and be ready to track and monitor what the impacts of these changes are on communities and on people. And I think more and more we're going to need to focus on bipartisan solutions, whether we want to or not. And there are many, many groups that are developing bipartisan solutions. This is a set of recommendations from the American Enterprise Institute and the Brookings Institution that look at aspects of family, work, and education. But I think as we continue to try to work through these difficult decisions and find some areas of compromise. I hope that we can all develop a shared understanding that when each person has the ability to prosper, we all prosper. And I think that is really reflected by what Nelson Mandela said, that while poverty persists, there really is no freedom in our society. Thank you.
Good evening. My name is Mitch Little, Executive Director of the Mayor's Office of Community Empowerment and Opportunity. I'd like to thank the college, Jim, Tom. Thank you for having me and your support. I'd like to talk to you a little bit about the role of our department and its work over the last 50 years in looking to eradicate poverty in the city of Philadelphia. This is an esteemed room. I was sitting here looking around at the portraits and listening to the remarks early on, and to sort of be a social worker and an anti-poverty disruptor in the midst of medical professional, it's a little intimidating. But what's also intimidating is the fact that at one time, like many of the people that we served, I sort of lived in a vulnerable state. I was unsure about my future, what life could offer me, and a path forward. And here I am sort of thriving amongst sort of thought leaders and partners to talk about this important issue. So that's the way we do our work. We work with families and individuals and communities to move them from vulnerability to a thriving state. And our work is in Shared Prosperity Philadelphia. You'll find us on the website. That term was chosen intentionally because at the time when our office was changed to Community Empowerment and Opportunity, it was a different climate politically. It was a mantra of what we could do together. And sort of taking on that mantle locally, we thought about shared prosperity in Philadelphia and how we could sort of raise the floor together to create opportunity for all. That's no longer the case. Today we start to see a place, sort of tale of two cities. We see great growth in one hand and opportunity. We see neighborhoods that used to be called the bottom, now called the innovation district. We see construction and skyscrapers from deep into neighborhoods of West Philadelphia and South Philadelphia. And yet we have a struggling school system. We have plenty of young people who are disconnected from school and work between the ages of 18 and 25, spiraling out of control, that cannot connect to a place that would offer them an opportunity in the land of innovation of the future. And so oftentimes we are having separate conversations about the same thing. What can we do to make this a stellar city, a world-class city, available for all? This is where our work started. 26.7% of Philadelphia is living in poverty. 37% of Philadelphia minors living in poverty, that's children, who are often food insecure, not understanding where their next meal might come from during the day. 36.5% of female-headed households living in poverty. And right behind that number, as you heard earlier, a group of Hispanics, high concentration of poverty, and African-American males. This is how we sort of organize our work. We start by removing barriers to increase access to services. And so some of our work is really sort of the low-hanging fruit, creating folks to financial security opportunities, benefit access opportunities, to really start to stabilize families. We concentrate on the hardest to serve, even though we start where a place of opportunity. And so it is not really going after sort of the folks who exist on the fringe, who can sort of, with minimal sort of supports, can sort of transfer over into equitable situations, but really going deep and really looking at some of the populations that I talked about, African-American men, female-headed households, things of that nature. And then we also employ a sort of evidence-based approach. In our work, it's a combination of art and science. It is understanding people. It is understanding behaviors. It is understanding how folks got there, but also understanding what are the available sort of evidence-based opportunities that we can sort of work with our partners, both in government and beyond, to create some strategies that work. It starts with a person-centered approach and a trauma-informed strategy. So when folks are looking at what's presenting, what happens when you and I come in contact with each other for however long, sometimes we do not consider what happened prior to that. Sometimes we do not consider who else you engage with. That be a healthcare professional, a behavioral health specialist, a teacher, a counselor, a coach. Sometimes we only concentrate selfishly on our rules of engagement. And so it's not what's wrong with you, but we all should be asking, what happened to you? Sort of historical and institutional trauma. We understand that vulnerable populations have often suffered from historical trauma. Talked about it earlier, African Americans, Native Americans, and women. And this trauma is often intergenerational. Folks are now growing up without an example of folks going out the house every day and going to work. For now, a generation. Understanding that there is little chance, intuitively, about social mobility because they don't see evidence of that in neighborhoods in which we work. And they understand, as you saw on the map earlier, that in deep pockets, there have been neighborhoods that have been left under-resourced until opportunity exists, until there is an opportunity for property and built environments to be seen as assets, and people not so much. Interactions with institutions can contribute to traumatic experiences. And so again, when folks are traveling through their days, they deal with evictions, cash bail systems, interruption of benefits, unreliable sort of work schedules, all of these sort of competing life activities daily, which increases stress and trauma on a daily basis. So it's this daily weathering of an individual that happens in neighborhoods with people that we work with. And then at the time that they present, someone might see them as lazy or apathetic. Again, always we should remember what happened to you. You saw this map in a different version. Again, this is poverty geographically. We also show sort of our place-based initiatives in some of the most hardest to serve neighborhoods. And so we do our work both citywide strategies, but also place-based initiatives, which is this infusion of supports and services, strategically working with partners under collective impact approach, in which we can sort of agree on goals, use mutually reinforcement activities, and agree on sort of data that helps support our work and move that work forward. So right now we are doing tremendous work in the Promise Zone, Promise Neighborhood area, Choice Neighborhood, the 22nd District. Some areas of interest for us is Kensington for obvious reasons, Frankfurt and Hunting Park to mention a few. Some of our sort of initiatives that I'd like to sort of share with you today. We work with the health department on our lead poisoning prevention program. We also work with EARU, which helps create with our Office of Homeless Services, they just changed their name, to create housing opportunities for folks who are at risk of homelessness. And then we also offer financial assistance to low-income individuals and families facing utility termination. Again, trying to stabilize folks so that we can maximize the level of interventions with partners and create significant change. Access to career pathways. We fund Center for Employment Opportunity, a national program that employs folks who are returning home from state penitentiary, doing crew work in the city of Philadelphia and for city departments. TANF, we work with a large single mother population, and also now starting to work with non-custodial parents as well, providing supports and trainings for them. Power Corps PHL is a program near and dear to our heart. This is for what's called Opportunity Youth, and they work with city departments to create semi-skilled workforce opportunities so that they can move into skilled opportunities within city government or beyond. And then one of our partners that we also fund, the West Philadelphia Skills Initiative, again, working in the Promise Zone and University City, where folks have the opportunity to walk out their door, to work opportunities, to education opportunities, the same thing that we all sort of want, right? Food security, we work with the Philadelphia Food Access Collaborative. We coordinate a body of both indoor and outdoor food providers, offering technical assistance and support to them. Meals and More's program, we work with a lot of faith-based partners, help them sort of mature smaller programs and creating emergency food opportunities for neighbors and community members. And then Get Hype Philadelphia, which is a wonderful program working with young people in Philadelphia schools and after-school programs around healthy choices and working with our partners at the Food Trust. Early learning education. We released a plan, a running start for every child 0 to 5 a few years ago. In that plan was the recommendation of universal pre-K. That recommendation turned into expansion of pre-K here in Philadelphia, where we now offer 6,500 free pre-kindergarten slots to income-eligible Philadelphians. We work with Benefit Data Trust. I'm getting that wrong. Benefit Data Trust, who operates our pre-K call center, and they provide telephonic assistance to connect folks to pre-K and also benefit access. We are now working on a one-stop enrollment center, which we look to create a platform to sit on the Compass system to be able to connect folks to early learning opportunity and benefit access throughout the state. So this is a partnership that we've created with the state and with Allegheny County. So we're very excited about that as well. So that's a little bit about our work at the Mayor's Office of Community Empowerment and Opportunity. And I thank you for listening.
Good afternoon. I'm Natalie Levkovich, CEO of the Health Federation of Philadelphia. I'm delighted to be here. The Health Federation is a nonprofit organization, public health-oriented organization that, with a mission of improving access to health and human services for vulnerable populations. And we do our work in a variety of ways, and much of the work we do involves programmatic involvement in some of the same kinds of initiatives that you've just heard about that are occurring in Philadelphia. We also serve as the regional network for community health centers in Philadelphia, and that will be the focus of my remarks today. You've been hearing about kind of macro level considerations at the national level, at the municipal level, and now I'm going to drill down into the safety net healthcare sector. So as a network of community health centers, of which there are 16 in the Philadelphia region, they are, what are they? They are providers of preventive and comprehensive primary care services. And they are located in medically underserved communities. These are federally designated communities that have many of the characteristics you've just been hearing about. You've been hearing about the impact of place, of zip code on people's health. You've heard about the concentration of poverty geographically, and that is where community health centers are located. And they're a particular provider type that are designed specifically to work in those communities and with under-resourced populations. So they treat people regardless of ability to pay. They are community-based in that they are not only based in the community, but they are also governed by majority consumer boards, and they hire from within the community to a large extent. They're small to mid-size businesses. So in many cases, they are neighborhood-level economic engines. They are very intentional about supporting local vendors. They create a hub that people travel to, and so their employees and their patients have lunch at the local luncheonette, stop and buy coffee at the local Wawa, buy a newspaper at the local newsstand. So who are their patients? Nationally, community health centers serve about 25 million Americans. And locally, something in excess of 300,000 individuals annually. Almost 97% of the population is under 200% of poverty, 57% insured through Medicaid, and 13% still uninsured. And many of those, of course, are uninsurable. So community health centers charge a nominal fee for people under 100% of poverty. Nominal fee might be $5 or $10. And up to 200% of poverty people pay for services on a sliding fee scale. And the patients have many of the conditions and many of the burdens that you have already been hearing about. So a disproportionate burden of chronic disease, chronic medical conditions, chronic behavioral health conditions, historic and current trauma and toxic stress. You heard about that from all three of our previous speakers. Limited access to specialty care, that is somewhat less of an issue with under ACA, but it continues to be an issue because most of our population, at least, is insured through Medicaid, and that still carries with it certain barriers. This is a population that has a high need for social services, not just medical services. And they have a variety of barriers. Some of the structural barriers are the inadequacy of housing or the inadequacy of safe spaces to congregate, to build community for physical activity and recreation, as well as policy barriers. Again, you've heard about some of those, but you know, the structural factors that perpetuate poverty, the lack of adequate minimum wage, the lack of paid family leave are just two examples. So what do community health centers provide to their patient population? So preventive and primary care. And I referred to the primary care as comprehensive primary care because all of this is bundled in to the primary care delivered by community health centers. So care management, you know, specific initiatives around specific subpopulations that carry particular disease burdens, integrated behavioral health. Access to behavioral health is a major obstacle for people living in poverty and in underserved communities, so community health centers integrate those services as part of primary care. Dental care. Huge undersupply of oral health and dental services for people who are publicly insured, and never mind uninsured. Social work services, nutrition education, outreach and enrollment in public benefits, and more that I'll talk about in a moment. But what's important here is that the reason the community health centers directly provide these services is because this is a population that has limited capacity and access to shopping in the marketplace to get those services piecemeal. So going on, additional services, the community health centers really provide the co-location of certain specialty care, in addition to the comprehensive primary care. So some health centers have podiatric services, have vision care services. They co-locate things like mindfulness and exercise programs and cooking classes. All of our health centers are recognized as patient-centered medical homes, and there's some evidence that the longer a health entity, a health practice has that recognition, the better their outcomes, their health outcomes are. So a lot of focus on quality, on shared learning, that is participation in learning collaboratives, in disease collaboratives. Community health centers nationally were leaders in that model of participating with their peers in quality improvement initiatives. Community health centers recognizing, again, the stresses on their staff, the stresses on their population, and the need for this broad array of services, integrating, expanding, and maintaining and improving quality. Health centers participate in a lot of special initiatives. So they have staff training in trauma-informed care, de-escalation, and reflective supervision. One of the goals of reflective supervision really is to take care of the staff who take care of vulnerable populations because of the inevitable impact on the helper. A number of health centers are currently in early stages of implementing medication-assisted treatment to address the opioid epidemic. They deploy community health workers, so they step outside of their walls, they make home visits, they hire people with lived experience who live in the communities being served. Cultural competence and language access, so they employ bilingual staff or have relationships with interpreter services and have participated in specific training, interpreter training that the Health Federation provides. They do the screening to identify the burdens, to identify the what's happened to you. They screen for mental health, for trauma, for substance abuse disorders as part of this integrated approach to whole person care. And as I mentioned, making home visits and being part of the community in ways that are beyond their walls. So that is, in a nutshell, what community health centers are and how they are specifically designed to address the issues of poverty that are inherent in the medically underserved neighborhoods in which they are located.
Good evening. Hello, and thank you for having me here today. My name is Imani Sullivan. I'm a single mother of 3. I've long lived in the residence of North Philadelphia. I'm a hard-working home health aide. I've been an active witness to hunger since 2008. I am also an expert on poverty. I'm sure many of you are familiar with the statistics of hunger and poverty. Over 25 Philadelphians live in poverty compared to the national poverty rate of nearly 15%. Nearly 1 out of 4 Philadelphians are food insecure compared to the national rate with 1 out of 6. But I'm not here to talk to you about statistics. I'm an expert on poverty because I have firsthand experienced issues of unemployment, hunger, housing, mental health, racism, trauma, and connected issues of poverty. I'm here to show the face of the numbers. I'm here to humanize the research and add the real life experience to the conversation on poverty and public health. I'm here to give the recommendations based on many lived experience for how programs and policies can work to be improved in the cities that we live in. Before I speak to you about my personal experience, I'd like to tell you a little bit about Witnesses to Hunger. Witnesses to Hunger is an advocate movement made up of people like me with direct experience with hunger and poverty. We had witnesses in Camden, Philadelphia, Boston, and DC. Our goal is to make sure that people who know hunger and poverty firsthand can speak our minds and share our experience in education with policymakers, the press, and the public on what it's really like to live in my shoes. We want to have a say in programs and policies that impact our lives. We do this in many different ways. We take photos of our experience and exhibit them throughout the country. We meet policymakers, public officials. We stay active in our communities beyond speaking engagements, interviews, rallies, meetings, and social media. I'm thankful for the opportunity to speak to you on this panel for poverty and public health because I'm a low-income mother with clinical depression. Poverty and health are two of the most largest important issues in my life. This is no secret that poverty and health directly impacts others. Economic hardship, negative effects on health, which leads to increase in economic hardship, which makes health even worse. Poverty just doesn't come with income or employment. It directly connects with family issues like mine facing every day. We can talk about poverty without talking about health and healthcare. We can't talk about poverty without talking about hunger and nutrition. We can't talk about poverty without talking about housing and energy. We can't talk about poverty without talking about education. We can't talk about poverty without talking about racism and sexism and forms of violence, all the issues that tie together. People are often called poverty, poverty is called the cycle or a trap. It's true, but it's difficult. It's time to break the cycle. As someone who's experienced trauma, I also like to mention that trauma contributes to the cycle of poverty. There's toxic stress of living in poverty as is a form of trauma itself. That's usually not the only trauma in low-income families that I have experienced. Trauma can also move poverty to worse, affecting physical, mental, behavioral health, development, and financial stability. This is especially in the case of people like me who don't have the resources or the help. Now I'd like to tell you a little bit about my personal experience on poverty and my depression. In the background, the shot you'll see I was taken by Witnesses to Hunger, and some of them have quotes just to give you a little bit of look on my life. Poverty has always been a part of my life. I have always struggled and made ends meet. I have struggled with depression for a while. Part of my depression is that I don't eat. I don't go outside. I don't want to see anyone. I've gone days without eating. There's no way to function on an empty stomach. I've often felt like I'm losing myself. Because of my severe depression, I was out of work for 5 years on disability. Even though I got disability checks, I didn't have enough access for my mental health services or my resources. I couldn't afford medicine and had to keep bouncing around from doctor to doctor. I don't even have to read this because I already know what I feel. It's crazy. Sorry about the papers. Walk around from doctor to doctor because of my insurance wouldn't cover the excess that I needed. So, as that wasn't incredibly difficult, I went back to work. This made my family financially struggle on my own. It's mental health worse. I'm sorry. Being on disability helped my family survive. But we were stuck living in poverty That's how I feel. I just feel stuck. At the time, we lived in an unsafe neighborhood because that's all I can afford. I felt unsafe to go outside. There was so much violence that I felt unsafe to be inside because of my depression. I secluded myself in my home. I isolated myself from my family and my children. Meanwhile, I still didn't have access to resources that I needed, especially not in my neighborhood. I couldn't heal unless I go outside. But I needed to go outside. I had no money. So like I said, I felt stuck. And of course, all of this was affecting my children. Just like every mother, I wanted the best for my children. Just like every mother, I want to be able to provide for my children. Every day I fight my body and mind to get out of bed to go to work. I have to try to save my own life. I'm doing all of this without treatment, without medicine, without access to any medicine. I still have no access to any doctors. Even when I seen the doctors in the past, I felt judged and disrespected. They made me feel like I was less than a human. Thanks to my new job, I've moved into a better home, slightly better neighborhood, but there's a park across the street where my children can play. There's more access to food and transportation and social services and other resources. But even with my new job and my new home, I still struggle. I still have to cut back. I still sell things to feed my family. Things are tight. It wears you down. Everything may go towards the bills or necessities. I've been working 2 jobs and still it's not enough. I haven't been able to afford childcare. I've been on the childcare waiting list since September. Until I get childcare, I had to pay $150 a week. That's my money that I cannot spend. That's the money that's getting taken away from all of the other bills and things I have to pay. To add to my struggle, I often been cut off of public assistance, and so consistently I have to reapply. Sometimes I get cut off because my bills, and I have to pay my bills late. Sometimes I get cut off and because I make too much. We call it the welfare cliff. You make a little too much money and they cut you off of all your benefits. So you end up with even less than what you have. It's likely that they'll take your money and throw you off of the cliff without any purchase. I have a little experience on that. In 2011, before I got diagnosed with my disability, I worked for a cleaning company, and my bills were backed up because I was getting paid so less. And I did overtime for about a month, and they found out that I did overtime, and they cut my food stamps, they cut my children, they cut my medical. At the time they were giving you maybe $50 for 6 months when you first start working. They cut the $50 that I had. So I was left with $120 a week to pay my rent and to pay my bills and to feed my children. At the time, that's why I took that picture. I was working cleaning City Hall. Yeah, that's great, right? I took this photo when I was in the way of doing my overtime job, wondering if I'd get cut off my benefits. I ended up going overtime for 58 cents and got cut off. I was just trying to do the best that I could to provide for my family. I was put in a situation where I was demanded to take, if I took the job, I was damned if I don't, damned if I didn't. I've been through so much in the past few years, and this is the better place, but I'm still not on the other side. I'm still dealing with poverty, untreated mental health issues. This is a part of my experience, but it's built into the system that we need to work and for it to be undone. Based on my experience as a low-income mother, here's what I can tell you. We need the system that works for low-income individual families. We need the system that will actually help people get out and stay out of poverty instead of trapping the cycle in poverty. We need programs to meet the people where they need to be met. We need the programs to take the next step. Here's what I see that we should do. First of all, we need to exceed access programs, benefits, and opportunities that allow people to thrive. We need affordable and efficient health care for all, including mental health. There's not a lot of people too sick to go to work, even though they need the money. And there's a lot of people poor to there's a lot of people poor to miss work days on sick issues. So they go to work even though they're sick. Neither of those situations are acceptable. We need to find affordable and sufficient daycare for everyone. We need to exceed the health affordable food program like SNAP, school breakfast and lunch, and the WIC program. We need more safe and affordable housing, neighborhoods, and connected resources. Secondly, the welfare cliff needs to be eliminated. People should not have their benefits cut off even if they just go over 1 cent. That puts people in worse positions, that where they earn less makes them nearly impossible to get out of poverty. They should be granted a deadline, earn income increases, rather than set them on a cliff to cut them off. This way, people can get put in the points where they no longer need the benefits and be in a better self-sufficient situation. Thirdly, the maximum minimum wage should be increased to the living wage. We need family-oriented labor policies made for sick leave and family leave. We need career regardless who suffer from mental illness and trauma, some things that help transition people with emotions and mental and behavioral health issues back into the workplace. We need programs that meet our unique needs and allow us to reach out and facilitate. I wish I had these kind of support when I was trying to get back to work. In addition, the culture of human resources as a whole needs to change to be more trauma-informal, trauma-centered, and respectful of people who are struggling with poverty, mental health, and related issues. It is so important to always have low-income people in spaces where the cases and solution to poverty are decreased. Thank you to the College of Physicians for inviting me to speak here today. I hope you will continue to advocate and encourage the support and participate in low-income people like me for this important conversation. Thank you.
Now I think it's on.
Really?
We can help you. Here you go.
Okay.
So I think we've had 4 really wonderful presentations addressing this topic from different angles in ways that really complemented each other. We started out with a big policy perspective, moved on to the more local neighborhood, talked about healthcare, and then heard from Imani about her critical perspective and returned to the policy at the end as well. So I think that was really wonderful. And so now we have some time for questions or comments from you all. So please feel free to come to the mic. You shouldn't, Tom doesn't have to introduce himself, but you should introduce yourself.
I'm not shy. Giridhar, you presented some data on different policies and how many people it lifted out of poverty. I didn't see a couple of policies that I've been interested in. I'd be curious to know if you know how effective they are in lifting people out of poverty, and be interested in Imani Sullivan's own perspective on how effective you think those would be. So one would be the $15 minimum wage. Does that make a big difference in according to economic models? And what would that do for you if you had a $15 per hour pay as opposed to what you're getting as a home health worker now? And the second is a more progressive tax structure. I'm struck by the fact that when you count Social Security taxes and Medicare taxes, that even low-income people pay a fair amount in taxes, and sometimes the percentages is not that much different from people like me. So would changing that to a more progressive tax structure make a big difference in terms of getting people out of poverty?
Yeah, I'll comment quickly. I think there's growing data on the health impacts of increases in minimum wages. I know you were asking about the economic outcomes, but I think we're seeing more and more published now on what the direct health impacts are. Birth outcomes is one thing that I've seen multiple studies published on recently. I think in terms of economic outcomes, I'm not an economist. I should have maybe made that disclaimer at the beginning, but generally, the analyses that I've seen about increasing the minimum wage, whether it's to $10, $12, $15, is that has real and positive economic impacts on low-income workers. I think the one issue that's always raised is what are the potentially negative labor market effects? And it can reduce the number of jobs that are available, but that's generally going to affect youth workers. And on balance, the economic impacts are substantially positive. There was an assessment done by, I believe, the Congressional Budget Office just in the past 2 years that looked at this issue nationally. I think you're right on in terms of the progressiveness and regressiveness of tax structures. So things like sales taxes are very regressive. And when you look, we can think about regressiveness in federal tax structures, but state and local taxes are even more regressive than our federal tax structure. So there are many states that have flat income taxes. That's another burden on low-income workers. So I think that's a critically important issue and one that we're actually exploring at the foundation.
Imani, would you like to comment?
Well, you asked me how would the $15 help. I'm scared to even make $15, to be honest with you. Exactly. I can't afford to make $15 and get food stamps at the same time. If I make $15, I still don't think that it will be enough for me to support the size family that I have with the income that is going on. And I still have to sell. See, I sell my children's clothes that's too small. I sell them to help pay my bills. So that's how I would continue. I would continue to do that because I don't want to have to struggle. Like I want to always have something. Like I have a saving pocket. Like I always want to have something in that saving pocket. And me making $15 an hour, I won't be able to do that because I won't be able to feed my family.
What if you didn't lose your benefits?
What if I didn't?
Yeah, but you got $15 an hour, but you wouldn't lose your benefits.
Now, if I wouldn't lose my benefits, that's something
That's a different story.
Now, if I didn't lose my benefits, then I think, well, I know it would help my depression because I wouldn't have to worry about how am I going to pay my bills. That's the most important. My mental. It will help my mental more than it will help my finance. I need to be mentally ready to be stable enough to go to work.
Go ahead.
Thank you to all of the panel. Brian, for your courage to be here.
Thank you.
I have two questions, and it can be answered by anyone. There were some really good examples, and I mentioned others that locally working with the private sector. We know, given our current federal government status and what is happening, that we're going to need to rely on increasing private-public partnerships. And I wanted to ask if there's some other examples of that in the field you might be able to share. My other question is on advocacy. It seems pretty clear that whatever happens with the federal budget, a lot of things are going to move to state control throughout our country. So my question is, this is all wonderful in Philadelphia, but we all know we have significant challenges in the Commonwealth of Pennsylvania. Any suggestions of these types of key messages that we're going to get down to the state? How can we advocate and educate our state representatives, not just those in Philadelphia, but the entire state, about these important issues and what they could do at the state?
Would anyone like to jump in?
So I can start a little bit. I think the need for public-private partnership is essential to move forward. Hey, listen, somebody said earlier, this is a moral issue, right? This is an issue of will, right? I was at an event last week in regards to the growth that is possible in what could be the Innovation District, or now a burgeoning Midtown in University City, and Brookings was there, and they said, it's not a resource issue. The resources that you have in Philadelphia is sinful, right? These large research institutions, Science Center, Penn, Drexel, I mean, just a huge concentration of assets and resources. This is an issue of will. One day this nation is going to be brown, folks. One day folks are not going to be able to get the talent that they need for their businesses, and folks have to make a decision that resilient folks, and when I talk about trauma-informed, it's not to say that folks are broken. Sometimes it's a tricky, slippery slope, and when we talk about, and we sort of push this issue of trauma-informed, and sometimes it sort of, for some people, it speaks to the brokenness of folks. No, it speaks to the resiliency of folks. Grit, aptitude, fortitude, all those things that they're saying that employers are looking for, the ability to be entrepreneurial. There is a pocket of folks just waiting and wanting an opportunity to work. And businesses and private and the public sector can work together to do some of that work. We're now working with the Commerce Department through the leadership of Harold Epps. It's working with the Managing Directors Department to work on two things: re-envisioning the workforce system, working with Philadelphia Works and workforce partners to re-envision the workforce system in the city of Philadelphia, and also as a large employer of the city, sort of helping folks create a temporary or seasonal opportunity and moving them to permanent situations and creating career pathways in semi-skilled and skilled occupations that might exist for city government and beyond. And so we are now starting to have those conversations and bringing businesses to the table who are interested and want to be early implementers, but we have a long way to go. But we are faced against a moment in time, and it is up to us and whether or not we want to take advantage of that or not.
Mm-hmm. Yeah, it seems to me you also, Rob, were talking about how do we speak to the state, for example. And it seems to me that it's important to understand who you're speaking to in framing the message. There may be an audience that is moved by Imani's story. There's an audience that may be moved by the issues of poverty as a moral dilemma. But there are people who are not, and who may be more moved by the work readiness framing, or the framing of return on investment, or the framing of the downstream unanticipated costs from the short-term upstream savings. So I think that that the important strategy to think about in that advocacy dilemma is to truly understand what moves your audience and be able to flexibly frame your argument accordingly.
It says it's green. Jim Bueller from Drexel. I was struck at listening to the presentation on community health centers and the mayor's office on community empowerment by the list of services and programs and things that you're doing. And then I was also struck when Ms. Sullivan got up and said that she wasn't able to connect to the things that you are telling us are available. So why do we have that gap between what sounds like is available and yet someone like Ms. Sullivan is having trouble getting connected? How do we solve that problem?
Well, let's ask her.
I'm not access to the resources that they have. From what I understand, in my area, the resources that they're talking about, we don't have them in our area. So that's the problem. Some areas have resources that other areas don't. And if you don't know nobody in that area, then you're not going to get connected down there. They're not going to bring you down there and give you some of their money. They wasn't going to let you stay where you at and you don't get nothing. So you have to, and this is part of my depression, I don't explore the city. If I go to one office and they tell me that I can't get no resources there, I'm back in the house, I'm depressed about it, that's it. I don't go to different parts of the Philadelphia to find out if we have the resources, because one, I don't know if West Philly has something that can help me, or South Philly that can help me. I live in North Philly. So how do I get connected with those resources that are available for me that doesn't know that they are available? From the area that I live in, they're not available. So how do I get access to the areas that are available?
So what's interesting is that, in fact, North Philadelphia has a lot of services and resources because there is a concentration of poverty, and a lot of programs do locate in North Philadelphia. So the disconnect is the interesting question, right? Why do people not know that the services are there, or why are they not being utilized by people who clearly need them? And I think the answer is complicated and deep, but as we've heard very eloquently, to be poor is hard work. You know, we don't make it easy. We don't necessarily co-locate, navigate easily, have a single door for eligibility for a variety of benefits. There isn't a streamlined pathway. And so I can totally understand why someone who meets a dead end, a blank wall, becomes discouraged and doesn't take that next 10 steps that we require of them. These are structural issues. It's really not about programs per se. There's a broader structural problem.
I agree. I think that's right. I also think it's an issue of scale, right? I have a $20 million department. A couple years ago, it was $4 million. So in the city who has the highest poverty rate, the 10 largest cities, I'm working with $20 million, right? So that's one. Two, we work through a network of community partners, a lot of times contracted agencies, and so I might be providing a service, or family might be receiving a benefit or a service from us, and our name's not on it, right? We might work it through United Communities in South Philadelphia. It's just to community members, it's another service that United Communities offers, and for me, that's okay, as long as they're connecting to a trusted resource that they can then spread by the word of mouth. Oh, did you know United Communities has this? It's from this date to that date, and all of a sudden there are folks there who are ready and willing to take advantage of that opportunity. The third thing I'll say is that the compoundedness of distrust that happens over time. So just like wealth accumulates over time, money and time creates wealth, right? Folks have internalized a distrust of systems, right? Doctors can ask, well, why do folks don't get the flu shot? Because my grandmother used to tell me about the Tuskegee experiment. I've got people in University City knocking on my door wanting to do research on the neighborhood, right? So there is this distrust that still exists of systems and institutions that has to really be dealt with so that folks can look at these systems and institutions as not predatory, but helpful, I think, as well.
Thank you.
Hello. Thank you for coming. I appreciate the panelists' input. I'm a graduate student at the School of Public Health in Rutgers, and I wanted to ask two questions. Basically, it's known in our field that education is higher education attainment rates are highly correlated with better health indicators such as income, health disparities, and so forth. So my question is, what is being done in terms of education in the Philly community or just in general? This is to all the panelists. And my second question is, if we talk about poverty, we can't talk about poverty without talking about race and class. There was a talk earlier this week about how in communities of color in the school system, African American students are twice as likely to be expelled from school, particularly at the preschool level. So I was wondering, what can we be doing for the communities of color here in the workplaces and at the school level to eradicate that type of racism? Thank you.
I can maybe start quickly. I think getting kids off on the right educational trajectory is really important, even when we're talking about higher ed. So investments in high-quality childcare and high-quality preschool pay off big dividends. And I think there are good data showing that kids who have exposure to those early experiences are more likely to enter into higher ed. One of the things that we're focusing on at the Robert Wood Johnson Foundation is this idea that kids need to not only develop cognitive skills, but maybe even more importantly in the early years is developing social and emotional skills. So learning how to handle their emotions, learning how to deal with conflict, learning how to develop friendships over time. And there's more and more literature showing that those soft skills are just as important for kids' long-term outcomes. One other thing I'll mention is that, as we see these big cuts to federal programs, it's like a big balloon. If you squeeze on one end, you just get more pressure on the other end, and that's states and localities. So states and localities are just going to face huge fiscal pressures because of these changes federally. And when you look at states' budgets, the two top spending items are Medicaid and education, and it's kind of an even split between K through 12 and higher ed because of all the state colleges. So I think there are a lot of risks inherent into these federal changes that we will probably be seeing over the next couple months.
Hi, I'm Alicia. I'm doing a 5-year program. My undergrad major is sustainable agriculture. My master's is public policy. But I'm also a server, so I work in the restaurant industry. One of the barriers I kind of wanted to touch on that I really didn't hear about is barriers to access for undocumented workers. Because we see a lot of undocumented workers who they themselves are undocumented. Their children has been ruled the right to school, the right to be receiving services. But I think that's like a very relevant public health issue that doesn't get touched on. And obviously they have extra barriers in terms of poverty, in terms of wage theft, in terms of language access. So, anyone have any comments?
Well, speaking from the primary care side of things, community health centers see people regardless of their immigration status, and there's a great intentionality in that. I mentioned that one of the things that we do is provide training for interpreters. There are a number of organizations in Philadelphia, not community health centers, that specifically focus on immigrant advocacy, community legal services, immigrant services, after-school programs, culture preservation programs, literacy, academic performance support. There's a free health center called Puentes de Salud in Philadelphia that exclusively provides comprehensive care to undocumented individuals, particularly Mexican immigrants. So, there are definitely a fabric of organizations, grassroots organizations, and more established organizations that focus on that population. But in fact, none of us knows what these uncharted waters are. At what point, we've had conversations about what do you do if ICE shows up in your waiting room. Theoretically, medical facilities, religious institutions are sort of, safe ground. Is it really?
Yeah, for sure.
So, my guess is as good as yours, and in terms of what the future holds in that regard. Are there people who care? Are there institutions that have focused on this issue? Absolutely. But, we're all in this together, and an organized community is our best defense.
So I think we'll take the 2 more quick questions, and then I want to give the panelists a few minutes to make any final reflections at the end if you have anything that you'd like to add.
My name is John Downs from Children's Hospital of Philadelphia. For many years, I was the medical director of a home care program for ventilator-dependent children. And these children had multiple disabilities. We were able to get psychiatric and psychological services for the children through Children's Hospital and other organizations, St. Christopher's and children's centers around the region. Where we encountered great difficulty was where Ms. Sullivan encountered difficulty was getting services for the parents who, often under the stress of caring for these profoundly complex children, would often be depressed or have other anxiety-related disorders, and getting them the mental health services was extraordinarily difficult, even for those with middle income. I'd like to hear your comments. Maybe things have improved in the last couple of years I've been retired, but I found this one of the most difficult parts of our comprehensive care.
In fact, there are publicly funded, Medicaid-supported, community-based mental health services, actually for adults, and a greater undersupply of mental health services for children and youth in Philadelphia. The problem that you're, I think, identifying is that there is a lack of family-centered mental health care. So, as much as we talk about 2-generation approaches and the intergenerational transmission of some of these toxic stressors and their consequences, the services are quite segregated. So if you're working in the children's system and you've figured out how to access those services for children, it's difficult to coordinate on the adult side. We see the same thing in non-medical, in non-healthcare systems where child welfare services are not necessarily fully aligned and coordinated with addiction services for parents. So I think it's more a matter of the coordination and linkage than it is the actual, literal existence of the services. And that goes back to an earlier question I think that Dr. Buehler asked about, the disconnect between the population and the service and the complexity of navigating.
So our last quick question. And
Hi, I'm Sharon Wolf. I'm a faculty at the Graduate School of Education up at Penn. And I think we heard a really strong case for the moral argument of investing in poverty. But I'm interested that nobody talked about the economic costs of poverty to our society. There's research that shows that we spend about $500 billion a year, and the consequences of childhood poverty on foregone earnings, healthcare costs, and the cost to society on crime. So I'm wondering if any of you can speak to, I mean, that could be a great argument to get a bigger budget for you. Does that come up in any of the conversations, kind of the economic costs, and actually that the return on investment of investing in poverty in particular in early childhood is very large. So I'm just curious to hear your thoughts on how that perspective can maybe be used to help persuade greater investment in these issues.
Yeah, I think it is. I think that that folks are coming around and understanding, to your point, the right argument for the right audience. And as sort of this country continues to be more fragmented, it's even more important to do that now than ever. I think that a part of what helps that is just the ability to understand our world in a particular way more comprehensively, and there are structural barriers and create our inability to do that, our inability to share data, our inability to understand how person A traverses through multiple systems and high-cost users and things of that nature. But we're starting to get there. Locally, Tom and I sit in the Health and Human Services Cabinet, which are the Health Department, Department of Human Services, the Office of Homeless Services, my department, and what am I forgetting? Behavioral health, right? And so this has just happened in the new administration. We have been working on it for a year now just to get a data share to share information between city departments, our own very city departments. And so I think that information and understanding of our clients and the impact, the economic impact, allows us to tell that story a lot better.
The only thing I'd add is there's sort of this constant dynamic between data and values. And I think sometimes we can assume that making an economic argument is going to change people's minds and their decisions on policy solutions, but it doesn't always. So I think keeping in mind the stories and really tapping into people's values is critical. We use unexpected messengers for our work around early childhood education and other investments in kids. One of our partners is the Council for a Strong America, and they are made up of 5 organizations that represent business leaders, faith leaders, law enforcement leaders, athletes, and there's one more. But those types of voices are really important in state houses like in Pennsylvania, but all across the country. They sort of bring a different perspective, and oftentimes they can just get in the door in a way that other messengers may not be able to. So I think that's one approach that has shown some success. Go ahead.
I think that they need people like me to walk in them offices and them facilities and tell them what's working and what's not working, because the program that they have is not going to work. It's just not. It's not. I don't know. I'm not trying to be disrespectful, but there is no statistic. There is no number. There is nothing about the pain and the trauma that I have to go through every single day with dealing with depression. I had an anxiety attack before I came here. I had an anxiety attack before I came here. I had to take 4 pills from that somebody gave me because I don't have no medicine myself. And I had anxiety because I was excited. It wasn't that I was scared or I was nervous or I was ashamed. I was overexcited. I have anxiety attack when I'm overexcited. So for someone to say that that should do this and this should that, no, listen to me. Listen to what I'm saying to you. The system is not working at all. At all. So if they want to figure out what they need to do, talk to people like me. Come in my neighborhood and find out what's going on with us, just so you can find out what's really going on. Not by what somebody put on a computer, not by this piece of paper that I done written on this table. Come talk to people like me. They'll give you on the aspect of what works and what doesn't work.
I think on that very important reflection, I think we're going to close unless one of our panelists has any additional reflections that they'd like to add.
I do.
Go ahead.
Well, I just want y'all to know that I'm a single black strong mother of 3. And I will continue to advocate and fight if I don't have no legs. As long as I got a voice that comes, a mouth that can use its voice, I'm going to keep talking. And I want y'all to keep having forums like this. Come to neighborhoods like mine and invite us. We don't know nothing about this kind of stuff. If I wasn't a part of Witnesses to Hunger, like me and you had the discussion the last time, if I wasn't a part of Witnesses to Hunger, then I would have known nothing about this. So y'all don't know nothing about, in my world, I want you to come see, put my shoes on. Walk down my street and duck them bullets. Walk down my street and gotta swipe that food stamp card and tell them that your card don't work or you ain't got no more food stamps on there. You try to come live like me. That's all I want to say. Just try to come live like me. Just think as if you were me when you go to decide on these new programs, on these new budget cuts. If that man with the orange hair come in my neighborhood and go through what I'm going through, he would not put us through all those different programs that's not working. It's not working. It's not working. So I'm gonna end y'all with, come. I used to live in Nicetown. I live in North Philadelphia now. I'm always outside of my porch, so I never had a porch in my life. I never had a porch in my life, so me and my children love to be on my porch. I live at 22nd and Lehigh. I'm always outside. Come talk to me.
Thank you. Thank you to all our panelists, and I think we had a terrific discussion, and we have a reception, I believe, right out here, out this way, that way. Okay, so thank you once again for joining us.